This program is brought to you by Emory University.
Good morning, everybody. We'll go ahead and get started, and slowly people will be coming. It's a great honor for me today to have to introduce to you Dr. Garcia, who's a professor of radiology and imaging sciences here in Emory University. Dr. Garcia is the leader in the field for innovations and developing new technologies for cardiovascular imaging, and most especially for nuclear cardiac imaging. He has been the president of the American Society of Nuclear Cardiology for at least 2 times. He is a master of the American Society of Nuclear Cardiology, and he is the founder president for the American Society of Nuclear Cardiology Foundation. He has named a game changer by Emory University in 2012 for his contributions to the technologies for cardiovascular imaging. And all of us know very well Dr. Garcia, and he is very well known worldwide, especially for the Emory toolbox, which all of us use every day, reading nuclear images. And it's of course used worldwide for the same reason, and also is continuously updated in order to perfect the interpretation for more accurate cardiovascular imaging reading. And we are glad that he's here in Emory University. So Dr. Garcia will talk today about the effect of recent advances in nuclear cardiology in our clinical practice. Dr. Garcia, welcome.
Thank you, Dr. Larakis, for that nice introduction. It's a pleasure to be with you here today and to share some of the things that have been happening in nuclear cardiology. You might be wondering, well, before I start, I should make sure you see my disclosures, which is required activity for every time I give a lecture. You might be wondering why I have the photo of Dr. Ernst up there. Well, we're in the Ernst conference room, but when I was preparing this lecture, particularly when he was in this room, I remember Dr. Ernst telling us often that the best presentations were those that only had 3 slides in it. He would say that no one can remember more than 3 different topics, so if you have more than 3 slides, it would not be one of your best presentations. So today you will not be hearing one of your the best presentations. But in his honor, what I've done is I try to identify 4 slides that if he forced me to take everything else out, those were the 4 slides that I would leave behind. So I would hope, I couldn't make it down to 3, but I hope that the 4 will be something that you can take home. So these are the 4 points I'm going to talk about. And this is more focused on clinical practice. I have to mention some scientific things, but I promise I'll do that very shortly. So it's the use of new methods in hardware and software which are being used all over the Emory system to reduce radiation and improve image quality. I want to clarify this use of percent LV ischemic burden from myocardial perfusion imaging, because now all the software programs, not only the Emory toolbox, but all the other programs, we're using very similar numbers, and I want you, very similar calculations, and I want you to at least understand how that's done and how it was used in the literature. The use of PET is becoming more and more popular in measuring myocardial blood flow, absolute blood flow, and flow reserve, and that's also happening within the Emory system. But also, there is the only point where I'm going to talk about the future, the work that many of us are doing. And I will point out the different trials that are happening here at Emory, and hopefully so that you also become a contributor to those trials, which includes the assessment of microvascular dysfunction from PET imaging. And finally, the use of phase analysis, also from MPI, to measure LV synchrony. This is a really more going into heart failure and more into the issue of guiding CRT placement. in this era of moving from volume to value that we hear so much, and we're hoping to get there, the value to me of a diagnostic procedure is not good enough if it doesn't guide the treatment. For a diagnostic procedure to tell you you need another diagnostic procedure in this era, at least is something that I would not want to be working on. So many of these things you hear from me, it's really to be very specific on how to guide the treatment of the patient. So starting with the software and hardware, you know, for many years, and I still use in a lot of sites around the world and in Atlanta, the dual detector SPECT camera was the instrumentation of choice. And for many years, it's been quite useful. The problem, there's a few issues here, and you can see the heart is quite small compared to the entire field of view, so you were paying a lot of money for the rest of the detector that was not imaging the heart. And also, I mean, honestly, this kind of setup was developed by Hal Anger 50 years ago, so it was time that it got updated. And so what you've seen now in the last 10 years or so is the design of new generation cardiac ultra-fast acquisition scanners. And to be honest, when this started, it was to do the studies very fast. And the initial trials that we did were doing imaging in 1 minute or 2 minutes. But what happened at the time, that's about the time that we started getting concerned about radiation doses. And truly, not so much because of nuclear cardiology, but the fact that our kids, from the time they were born to the time they got to be my age, could have hundreds of radiation studies, particularly CT, because CT is a very good technology, but it's being used for everything. So the CDC down the street told everybody we have to be concerned about that. And so what the entire field started doing is moving more from just efficiency to also reducing radiation. And I'll briefly talk about that. So here what you see is two detectors. They're multi-detectors. The D-SPECT scanner that has 9 solid-state detectors, and this is what you find at Midtown. And the DNM 530C has 19 solid-state detectors, and this is what you find here at Emory and at the VA hospitals. And what you can see is not only are you seeing more than 2 projections, but they're solid-state. They give you much better energy resolution, and they have better spatial resolution. They call it tungsten, which means it's even better for thallium imaging, I-123 imaging. And you can see here the 19 projections from the DNM scanner. Now, the beauty of this scanner is also that it doesn't move. So the 19 projections are being done simultaneously with no movement, very similar to what happens in PET. And so the idea here is that maybe someday we can do this for dynamic imaging and also to calculate flow. I will talk about that, the challenge of SPECT compared to PET when that comes around. But beyond the fact that we have new detectors, and as just mentioned, it's all over the Emory systems, we also had computers fast enough to implement algorithms that we knew from 20 years ago. So a lot of you have looked at images that look like this, and they come from a patient that looks like this with a defect down here, and this is a cartoon of what the count profile might look like with noise. So what we used to do is smooth those count profiles and get rid of the high frequencies. And so we get a nice smooth imaging, getting rid of noise. What is done today with everything we're talking about is model it with techniques called resolution recovery and noise regularization, so that the response or the count profile goes right across it, and you can see this is the same exact patient from the same exact dose. This was imaging 2 minutes. This was images in 12 minutes. And you can see the superiority of the image quality. Again, what you find here in the Emory system. So if we look at the protocols we were using here in 2008 with the dual detector system, the minimum dose we would use was 10 and 30, 10 for rest, 30 for stress, compared to, well, as the patient got larger, we would use a higher dose. But compare that, the minimum dose we used in 2008, to what we're doing today, which is we're giving 7 at rest, 21 at stress, and that is the maximum dose we're using with just changing the acquisition time. So now we can see that this is one of the things to remember, that what we've been able to do in these few years is reduce the radiation. I didn't show you that we also are doing the studies faster. The SPEC studies are done in 2 minutes or less. We moved to the 721 is a minimum of reduction of 30% radiation with better looking images. If we do a stress only, which about half of our patients are done that way, is 1.8 millisieverts. That's a reduction of almost 83% radiation. We tend to have about half and half of these, so it's roughly 66%. Of course, if we do PET, one of the beauties of PET is not only that the pharmaceutical goes very quickly through the patient, so the radiation goes quickly through the patient, but the fact that you have detectors going all around it, so it's only a 3 millisievert radiation, and that's a reduction of 70% compared to the conventional doses we're using in 2008. So, and at Midtown, you know, they have a stress rest protocol with thallium and technetium, also significantly reducing the dose. I neglected to ask them what they were using in 2008, so I don't know how much they have reduced it. But because those D-spec systems that they use are very efficient, I'm sure they reduced it by at least 40%. So that's the first topic. And the idea there is, if the patient asks you about radiation, you say, look, we have significantly reduced radiation. Honestly, I wasn't worried about the radiation in 2008. I had a bunch of those studies myself. But you shouldn't have to worry. And if I have more time, and this whole topic was about radiation, we could talk more about that. But we have significantly reduced radiation. And what I'm proud of is we did it with increasing efficiency and image quality. So I think we're in good shape there. So let's move on now to quantification. And you know, for many years, Stam talked about the Emory Cardiac Toolbox, which is similar to what Cedars and INVI and some of the other people use, is this idea that you look at a normal distribution, and then you compare that normal distribution to your patient's distribution and see what the differences are. And you can see here in both SPECT and PET that the normal distributions can be quite different depending on the radiopharmaceutical that you use and the instrumentation that you use and the specifics of the protocol. And we've used that for many years. So in a couple of minutes, in about 5 minutes, I'll talk about moving from there to absolute flow. But the important thing here is this issue that because we used it for so many years and we have so much data, we're beginning to understand a little better what these numbers mean clinically. This is a study from Rory Hakamovich that is really the foundation of the ischemia trial. And the idea here, and there's confusion with this, and one of the reasons why I wanted to mention it today, is what are the, when you say 10%, what do you mean by 10%? So this study had to do with whether revascularization was associated with lower risk of cardiac death only in those patients with greater than 10% really ischemic burden in the left ventricle. So if you look at these two curves, and I know you've seen this many times in different ways, but patients below this number actually had lower risk if they were treated with medical therapy, and with higher number, lower risk with revascularization. So how do we measure this ischemic burden? So here's a study. And I want to ask you, will revascularization reduce risks of cardiac death on this patient? So I'll give you 15 seconds. So how many of you think that it will reduce, if you revascularize this patient, you will reduce the risk of cardiac death? How many? Well, it happens to be me. And my surgeon is here. So you can see that from the study, there was a significant stress-induced perfusion distribution. and it reversed quite a bit. And if we look at this number here, so 31% means what? 31% is the stress-induced perfusion defect. And here this number is measured by looking at the 17-segment model, which, as you know, is the convention in cardiology imaging. Each sector can go from 0 to 4, where 0 is normal and 4 is totally absent. And then you sum those numbers, and which is the sum stress score, and divide by the 17 segments by 4, which is 68. So 31% of the myocardium is hypoperfusa stress, and 25% of it improves. So you do the same thing here in the reversibility scores. Again, from 0 to 4, you add, this is called the sum difference score, is 17. So 17 times 100 divided by 4 times 17 is 25%. 25% is above 17%, 10%. So it is expected from this large trial, this meta-analysis that Rory did, is that I would improve, my risk would be reduced post-revascularization. Now, I show these slides for many reasons. One reason is to talk about this measurement of percent ischemic burden. The other reason is because you can see I have a very clear defect in the lateral wall, but in fact, I know that I have multi-vessel disease. So even though it appears to be more normal because of this relative quantification, it is not giving me the correct distribution or the correct severity and extent of the disease. So that's the other reason that I show this slide. The third reason is I don't have to worry about HIPAA. And the fourth reason, and you can see that I have Dr. Ernst's image here because I want you to remember this number, but this slide really reduces the number of tough questions I get after I finish the presentation. Think about that one. Okay, another patient, and this is not me. So then the question is, do you see ischemia here? And would this patient risk be reduced post-revascularization? How many of you think it would? First of all, how many of you see ischemia? And how many of you think it would reduce post-revascularization? So yeah, you see ischemia, and it's not too difficult, right? It's down here. You can see the numbers. The sum stress score is 13. The sum rest score is 10. So if we move to a similar display, we see that the difference, so yeah, it detects it, it looks at it, it improves, but the improvement is only 4% of the myocardium. So this is the type of patient where we see confusion, because there is no question there's a defect there. There is no question this defect is ischemic. And in fact, if you look at this way, where it says, I'm going to look at each pixel to see if it significantly improves, it says 78% of this defect improved. But the amount, the magnitude of the improvement is only 4% of the left ventricular myocardium. Now, you may want to believe it or not believe it. You might still want to send the patient to the cath lab and have the patient revascularized. But if you look at the schema trial and you look at Rory's Akamovich number, it predicts that this patient risk of cardiovascular disease would not, cardiovascular death would not be reduced by that. Again, you could also disagree with the program. You could say, well, this is not really a 3, this is really a 2, and then you could do the numbers. But to get to 8%, to get to 10%, this number has to be closer to 8 or 9. So it's quite far away from it. So second topic, and that's the reason I wanted to clarify. So, and that's there now in all these programs. It's definitely in the Emory Cardiac Toolbox version 4. It's not in the, some of you in other hospitals have version 3, so that you might not have seen that yet. But that's where the number comes from. Now we're going to move from relative perfusion, this idea of comparing to normal databases, to actually measuring absolute flow and flow reserve. And the title of this presentation is Recent Advances. Really, UCLA has been doing this for 30 years. We working in research protocols, for example, with Dr. Vaccarino, have been doing it for at least 20 years. But the beauty here is that it's reaching now the clinical arena where we can start using it on our patients. I will mention that, and this is being done at Midtown, what Dr. Parson told me is every patient that is acquired, both here at Emory and at Midtown, with PET rubidium, is acquired so we can measure the absolute flow. Because it takes about 20, 30 minutes additional processing, we're only doing it on specific patients. At Midtown, it's being done when the interpreting physician requested. At Emory, it's being done with the referring physician requested. For us to be able to do it on every patient, we need one more computer, a little more time, and I think in the next year or so, we hope that we'll start implementing this so you can get it on everybody. But the idea here, and you will see that the concept is not that difficult, is that you capture the rubidium as it's going through the heart. And you see, for example, here, the flow through the right ventricle, left ventricle, and then sticks in the myocardium. And you will see in a moment the equations that I used to do this, which are not all that difficult. But then what is done clinically by most people for many years is just look at the flow reserve for the entire left ventricle. And the reason for that is the larger the area, the larger the mass of the left ventricle that you measure, the lower the noise and the better the accuracy. But there are some problems with just looking at the entire left ventricle. But just like we've done with other things, not only you look at the global flow and flow reserve, but you can break it down into the generic vascular territories for stress, rest, and one divided by the other for the flow reserve, or you can break it down into the 17 segment format. Now, these slides look a little complicated. It is not that complicated, the idea here is for you to see and understand that the equations, which have been around for many years, are well understood, and that this is how we measure flow. We look at the first pass through the left ventricle, so this is through the chamber, and then we see how much of it is captured into the myocardium, and roughly in about 2 minutes, we look at the concentration in the myocardium divided by the sum of the concentration of the input function. In the old days, this was complicated because you would actually measure the arterial blood concentration, which you can imagine it was complicated and somewhat painful to the patient. Now we just put a region of interest in the middle of the left ventricle, and that becomes our proxy for the arterial blood concentration. So if we just divide one by the other, we get flow multiplied times the extraction fraction. So again, you see something like this, you get discounts, you sum this, that's not very difficult. We can do that, and it's been done for many years for the entire left ventricle. You can do it for a region. As you'll see in the research that we're doing, we can do it point by point below a vessel. So we can measure flow as it's moving down the left ventricular myocardium. Now, what about the extraction fraction? Well, so the extraction fraction is a little complicated. It's different for different radiopharmaceuticals. You can see this is the equation for nitrogen, and this is the equation for rubidium. The other thing that complicates it is the extraction fraction is a function of flow. The faster the flow, the lower the extraction fraction, because the cell has less time extracting it through there. But the other complication is what you see on this slide. And this slide is we are plotting absolute myocardial blood flow versus the measured blood flow. And here what you see is without correction for the extraction fraction. And you can see that the gold standard is really O15 water, but the O15 water PET studies are not very good for diagnosis. So what, as you know, what most of us use is rubidium or ammonia. you can see that it's significantly lower, but we know how to correct it. And because with PET, we get so many counts, we can do that correction, basically bringing the curve from down here to up there, particularly for the hyperemic response. Now, just a little bit of look at the future. There's this agent called F18 fluoropyridase. It almost has 100% extraction fraction, sticks to the myocardium just like sestamivir. So we could even do exercise PET with those patients. And so it's already in phase 3 trials, and we hope that it will be available clinically. But right now, we got to stick with rubidium and ammonia. What about doing this with SPECT, as many people ask? Well, you can see the problem with MIBI and tetraphosphamide is two problems. So it's not really the SPECT technique itself, it's the radiopharmaceuticals. The fact that the extraction fraction is so low that you have to correct quite a bit, but beyond the fact the extraction fraction is low, is the fact that and even though we have those fancy detectors we talked about at the beginning, there's still not enough counts to reduce the noise of the measurement. So the measurement with SPECT, at best today, we can look at the global left ventricular flow reserve, but it's very difficult to look at it regionally. Okay, so here we see another important slide. So here's a patient with similar to the study that I showed on myself. It's a patient that is a rubidium study, rest and stress, and you can see a very clear defect here that reverses. And you would say, yes, absolutely, this patient has ischemia and disease. But if you look at the hyperemic absolute flow, you can see that the entire left ventricle is reduced in flow. And the same thing if you look at the flow reserve. So again, the take-home message here is that often the SPECT studies and even the PET studies don't give you the entire vision of what is going on in the myocardium in terms of hypoperfusion. And the main concern is a patient with so-called balanced reduction of flow. Because even though that doesn't happen as often, and the heart is not that smart that it reduces flow exactly the same everywhere, there's always some relative reduction that you can pick up. But it's been shown, depending on the protocol that you use, that patients can be found with triple vessel disease that on a SPECT study might look totally normal. So the idea of moving forward to using absolute flow and flow reserve, it's an important one. And you will see on the next slide, we're trying to make it even more important from the point of view of image-guided therapy. Now, in terms of numbers, the flow reserve, what is happening today, agreed by the experts, it might change tomorrow, but if the number is greater than 2.5, that is, if the hyperemic response is greater than 2.5 times the resting response, then you call the patient normal. If it's less than 1.5, you call the patient abnormal from the point of view of flow reserve. If it's in between, then you have to be a lot more careful looking at the patient. Why? Because in many patients, resting flow increases, and because of the heart rate blood pressure product. So if the product is high, the resting flow is high, so the flow reserve is down. Now the question is, we're seeing more and more that patients with disease do have resting flow that is high. So maybe it is a good finding, but of course the patient could also be nervous or, had to face traffic on 400, and it started out with a very high pulse pressure product. So now, we do know from many trials now that if we just look at anatomy, it's not the entire picture, particularly in patients with stable coronary artery disease. We know from the COURAGE trial that anatomy-guided PCI did not provide a prognostic aid. We know from the FAME trials that the FFI-guided PCI gave us better result than anatomy-guided PCI. We know from the FAME2 trial that PCI was better than medical therapy when the FFR was less than 0.8. And we know from the defer trial that the PCI can be safely deferred when the FFR is greater than 0.75. But we can't be fooled by thinking that physiology is also the entire picture. So in other words, if you really want to guide therapy, you also need the anatomy, as you all know. And so we move forward to what we hope is the next step. And this, unfortunately, is not clinically ready for use. But the reason that we bring it here is because of the fact that we are doing active research. We have ongoing clinical trials. And in this trial, so what we're trying to do, what you see here, is it starts out by a patient showing ischemia on PET. And we will do then a CTA study on these patients. The PET was done clinically. The CTA is done paid through research funds. And then with the hope that this patient, we make it to the cath lab, and we can do an FFR on those patients in those vessels. So again, this is the idea, and then I'll go into the three different trials that we got going on. But the idea is that if we look at this hypoperfused myocardium, as shown by the black dot area, and we looked at the anatomy from the CTA, and we can compare the two, we can better determine what's going on with the patient. This is an old slide looking at relative flow. But you will see where we're going with absolute flow in a second. But just to, for you make sure that you know about the three trials that we have going on, Dr. Samedi with Dr. Giddens is using this data to validate FFR from CTA, particularly with the fluid dynamics being developed by Giddens and the group there. So in other words, the same patient we're trying to use for three different trials. So it's really more of an appeal for you to be cognizant of this, and you help us recruit these patients. The work that we're doing with Dr. Piccinelli, who's here in the room, who's developing these techniques, but together with Dr. Samedi and Dr. Esther Hardy, is the vessel-specific flow reserve and absolute flow, which I will go into it in a minute, and then looking at microvascular disease with various, with Parham and other people in the department. Okay, so what happens here? Now we're going to go into the research arena. So this is not ready yet for clinical use, but I surely hope in 2 years we can offer this to you. So the patient has to undergo CTA. The CTA has to be processed. And the idea to process a CTA manually takes forever and will never be used clinically. So together, working together with Dr. Yassi at Georgia Tech, we're developing and validating techniques for automatically detecting the endocardium, epicardium of the left and the right ventricle. And when you do that, you form these three-dimensional images of the myocardium, which also gives us, importantly, the myocardial mass locally, because that can be used. One thing I neglected to tell you when I talked about flow with PET is that the flow with PET is somewhat different than the flow through the coronary vessel, in that is mLs per minute per gram of tissue. So the ability to be able to correct for the true grams per tissue gives us yet an additional improvement in the accuracy of the technique. So here we see from any CTA that we do is that we look at, of course, the chambers, and we look at the path of the coronary vessels. In here, in the technique that I show you that we're using from the PET point of view, we don't need a really good definition of the vessel, just the path. For the FFR CTA, yes, you do need a very exquisite representation of the vessel, because as you know, that's going to be used for the simulations or the measurements with fluid dynamics, modeling hyperemic response and resting. So this is part of that first trial that I talked about down here, but up here it has to do with what we need for PET to look along the vessels. So what we're doing, again, Dr. Piccinelli's work, is now that we have the myocardium, we look just below the vessel, and we're going to measure flow and flow reserve at each point. That equation that you saw is going to be determined for each of these points, and we'll be able to separate, we hope by the time we validate this, the flow from one vessel with the flow from the other vessel. So what happens when you look at a whole region, or you look at the entire heart, is you're mixing normal flow with abnormal flow. So you're losing the contrast of detecting flow problems along the myocardium, and it's very difficult to tell which vessel is responsible, culprit for the hypoperfusion that is taking place. So again, for image-guided therapy, we're hoping once we validate it that we can do this. So just like we done before, we developed normal databases, except that now they're absolute normal databases, and they're absolute in terms of ml per minute per gram of tissue, going from the base of the vessel all the way, so proximal to distal. And now we can compare in this patient, as you see, green here is the first diagonal, the blue is the main trunk of the LAD, and you can see that the hyperemic flow is reduced where the first diagonal is normal, both whereas they're both normal at rest. And for hyperemic, for flow reserve, we can see again the LAD falling below the first diagonal. So the idea is the following, is that if we look at just the path of the vessel, and we look at flow just below the vessel, we can measure that flow and provide this type of three-dimensional coronary distributions that are giving you the numbers, so it's color-coded to the absolute flow going on. So yeah, behind the scene, this is what's going on, and perhaps we will mark the exact region where the abnormality took place, but the idea here is not only to tell you the myocardial wall where this is happening, but to tell you the vessel and the location in the vessel where this is taking place. Here we see another patient and a little better defined in terms of the coronary tree. And you can see this patient, and we had these results before the patient went to the cath lab. So we knew that there was a significant flow reduction in the PDA right here. Now the question is whether an interventional cardiologist can look at this and say, you know, I can't get to this vessel, so it's not even worth going into the cath lab. Of course, maybe until you get there, you don't know in terms of how difficult it is to get to do a PCI over here. But the interesting part is this patient had a stent put in the first diagonal, and according to our flow calculations, there was a lesion there, but it was not a significant lesion. So again, the idea is for us to be able to prove not only that these are pretty color pictures, but that these are in accordance with what we find in terms of physiological measurements in the cath lab, so we can guide the therapy. And from the point of view of looking at microvascular disease, remember, we're measuring flow right below the vessel, so these regions are placed right below the vessel. So what we're really looking at is what's going through the microvasculature. Of course, if there's an epicardial flow reduction, it affects the microvasculature. But if there isn't, if the epicardium is intact or just not significantly reduced, we should be able to separate the epicardial disease from the microvascular disease. Again, you can see that there's still quite a bit of work to get there. And this is a concept slide from Lance Gould's group, and you can see back in 2012. If you look at coronary flow reserve, which I rather call myocardial flow reserve because that's where we're measuring it, and we find a patient where the FFR is high, but the myocardial flow reserve is low, this must be related to microvascular disease. Okay, so we move from there. Remember, the main concept there, clinically, that you can use right now is patients with triple vessel disease might show general flow reduction along the entire left ventricle, where if you look at it relatively hypoperfusion, it might be just one region, and you might be confused into thinking the patient has single vessel disease. Moving on to the last topic, and this we've been working also for about 10 years, but it's making it now to the clinical arena, is this idea of using myocardial perfusion imaging for measuring left ventricular desynchrony. So specifically, we're looking at the left ventricle and how the left ventricle thickens. And we can measure the region in time when each segment is beginning to thicken. And with that, we can measure the synchrony. So let's see how we do that. So how can we measure it? How accurate is it? What are its clinical characteristics? And the most important thing, how to use it to predict response to resynchronization, and how to guide the placement of the electrode. So you know that synchronicity is really homogeneity of the onset of contraction, is the time when the electrical wave, and it's usually the way, of course, the electrophysiologist thinks about it, it's the time when the electrical wave activation reaches the contractile segment, and that's an electrical wave. But when that wave gets there, the myocardium starts to thicken, and that is a mechanical wave. And then that's also the time when the endocardial segment begins to move. That's also a mechanical wave. And we know that there's of course, when the synchronicity is normal, then you get agreement with the electrical and mechanical waves. But when there is desynchrony, it's been shown that the electrical activation is not necessarily equal to the mechanical activation. Now, which one is more important? From the point of view of pumping the blood, the mechanical activation is more important. From the point of view of fixing the electrical wave is more important. Now, how do we do this? And we have about 30 papers on this, and when we send it to a cardiology journal, we always get the same questions, basically saying, how can you do this? So if we look at a segment of the myocardium and we look at the count change throughout the myocardium, we know, we've shown that many years ago, that the change in counts is directly proportional to the change in thickness. So now, you know, in the Emory protocol, we're only using 8 frames per cardiac cycle. And yet, when I show you the propagation of the mechanical wave, you will see we're doing it almost at 100 or a millisecond, 10 millisecond segments. So the idea here, from the mathematical point of view, and if you have advanced mathematics, this is simple for you. If you haven't had this kind of engineering type of background, you probably don't believe it. But if we see the counts in this segment at 8 different times in the cardiac cycle, we can replace those discrete counts by a continuous wave. And once we have that continuous wave, the question is, as to where the onset of contraction is where this line crosses that line. And what I need here is not more frames, it's more counts per frame to reduce the noise from not having enough radiation at that point in the cardiac cycle. So I know I said that fast, and you're necessarily going to believe the mathematics, but accept it for now that we can measure these points, and we can do this along every segment 3-dimensionally along the cardiac cycle. And then what we do is we're going to give you polar maps, and these polar maps, instead of being perfusion or function, they are onset of delay. So this is the phase, the further along, so this is the beginning of the cardiac cycle. This is the end of the cardiac cycle, shown in degrees. One heartbeat is 360 degrees. And you can see that this is earlier in the cardiac cycle, this is later in the cardiac cycle. If we look at a normal patient, this is what it looks like. So this is the perfusion, and this is the onset of mechanical contraction. Contraction is going to start here, and it's going to propagate to the septum and the lateral wall. So we're going to then show you, when it gets to that color, we're going to blacken it over here, so you actually see the contraction moving. It's giving you the synchronicity. But so So you see this in various ways, right? The frequencies is how many segments have this particular onset of contraction. So if everybody contracts at the same time, it's a very narrow segment, very synchronous. If there are problems, it's like the previous slide, this histogram is quite spread out. So we developed normal databases for this also years ago, and the main parameter that we're using is the standard deviation of this distribution. Here you see a patient with left bundle branch block, which of course is usually the ideal candidates for resynchronization, but yet this patient is still pretty synchronous. And just because it's not normal, it doesn't mean that this patient would benefit from resynchronization. So that's where the question is how can we help not only predict which patients are going to benefit from synchronization, but actually guide the actual process. And you can see this looks very different than what we saw before. The onset is a lot closer to the septal wall, and then it's propagating to the lateral wall. This is interesting. This is a patient with a subendocardial MI, and what makes it interesting here is this is the region of the subendocardial MI, and from the hypoperfusion you see it here, but you also see this is the last segment to contract. So by looking at this contraction pattern, which is still pretty synchronous, in other words, this patient would not benefit from resynchronization, it is telling us that if there's an infarct or even a subendocardial infarct, it's going to be moving further and further away from the beginning of the wave of contraction. Patient with total transmural MI, and you can see it here, and you can see that there's quite a bit of synchrony between the part where there is the infarct and the part where it is thickening normally. Okay, so now this is a patient, just so that we look at these histograms before and after successful resynchronization. So this is the histogram of the patient. You can see how wide the distribution is before the resynchronization. You can see what it looks like afterwards. Significantly improved both clinically and mechanically. What about these two patients? So here we see two different patients. Both they have ejection fraction by echo of pretty low. You know, from the Miracle trial, the FDA approval of resynchronization calls for an EF lower than 35. So both patients have class 3 symptoms. Both patients have EF lower than 35. So the question is, will both benefit from resynchronization? This is the first patient. And you can see that this patient is actually quite synchronous. So one thing that we've learned now after 10 years of doing this is that if the patient is not desynchronized by significant amounts, the patient will not respond to resynchronization. In fact, in our experience, looking at data from about 40 different sites, not Emory, and we don't look at Emory data for a couple of reasons. One is that these patients are not usually, you don't do MPI in those patients here. But patients that look like this, they try to resynchronize them, they come back, over time, they get worse. What about the other patient? Well, the other patient looked like this. It was quite desynchronous. So here, resynchronization, you'd expect to get improve the patient. And this is exactly what happened. This patient, this is before synchronization, actually went to class 4 heart failure. This patient went from class 3 to class 1 with an improvement in ejection fraction. So we try to start predicting who's going to respond and who's not going to respond, and we didn't do very well. So with this cutoff of 43%, this is working with Jerome Bax's group in Leiden, who has a tremendous amount of data. We saw that still we were roughly similar to what was happening in the echo trials of sensitivity and specificity of about 70%. So then, and this you can see is the part of the take-home message, what we learn is you can just predict it, you have to guide it. So not only should the patient have EF lower than 35, the LV should be desynchronous. And as you know, if you're an EP person, that this QRS number keeps changing. It started out being 120. In Europe, it's now 150. So you're still looking at what it should be the correct cutoff to do their synchronization. Mechanically, it helps you determine that. But the other two things that you have to put into the equation is that the wall where you place the electrode has to be viable. If you put it in top of an infarct, again, the patient is not going to improve. In fact, most of those patients get worse. And preferably is the last segment, viable segment to contract. So now the issue is, can we then do that? Can we measure viability and tell you which is the last segment to contract? And you can see in this trial, also working with Jerome Bax's group, that was published in 2011, that when we looked at 90 patients, and we looked at whether the LV lead position was close to the latest mechanical activation by our phase prediction, in fact, we got a significant improvement, whereas when they were not, when they were discordant, the patients did not do so well. And here is the data. In terms of ejection fraction, concordant, afterwards, significant improvement, discordant, no significant difference, concordant, and this to me was the most remarkable result, is patients actually, the volume of the left ventricle got smaller over time, so it was reverse remodeling. So the idea now is also to guide, so not only to predict it, but to guide it, and here you see a patient that is what we call a super responder. And this is before and after the therapy. And you can see in 6 months, this patient went from a 22% ejection fraction to a 49% ejection fraction. And the end systolic volume went from 199 to 111. Tremendous improvement. It almost, you know, the miracle trial sounded like a miracle, and some of these patients looked like miracles in terms of their improvements. Now, we still found out that that wasn't enough. Saying where in the myocardium to put it wasn't enough. You have to be able to do it in real time during fluoroscopy. So the research that is being done now, that we published it in JACC Imaging in 2014, is being able to reconstruct the fluoroscopy in 3 dimensions on top of the LV and looking at the latest viable segment to contract, so we can actually be able to lead the probe. Now, as you know, if you're in that area of electrophysiology, the electrodes are getting more and more fancy in terms of the ability of changing the activation from one part of the electrode to the other, and that has helped quite a bit. But here, the idea is to find not only the right vein, but the best location within the vein to start the onset of the activation. Now, we've been doing this for 10 years, and every time I show this to electrophysiologists, and I ask them, do you ever look for, there's an infarct where you're placing the electrode, or do you ever look for the latest segment to contract? The answer is no. And the answer is usually, it's not in the guidelines. And so what we're trying to do for the first time, which is painful, is to change the guidelines. And the way that we're doing this is we have 2 international clinical trials. The first one is called GUIDE CRT trial, and it was sponsored by Medtronic and the Chinese healthcare system in 20 Chinese sites, and this is already finished, and the manuscripts are being written. So I can't, unfortunately, tell you the results, but let's see what it says. And then we have a second trial, the Vision CRT trial, sponsored by the International Atomic Energy Agency, 11 sites around the world, and the last patient to be recruited will be December of this year. So hopefully by the time we get this done, we'll have enough data at least to convince people. So with that, I'm finished. I wanted a few more minutes of questions, but I'll be here if you have, if you want to stay around and ask questions. Thank you for your attention.
Thank you very much, Dr. Garcia, for this excellent presentation. We'll take a few questions since we started a few minutes late.
Ernie, that was fantastic as usual, but let me go back to your first premise that you might live longer if you get revascularized with more than 10% ischemia. So the ischemia trial is based on function. On the other hand, form, as you point out, is important too, maybe. And taking the case that did not require HIPAA surveillance, from that scan, that patient could have a totally occluded circumflex marginal, big one. On the other hand, that patient could have a stenosed marginal, moderately tight LAD, same thing in the right. And in terms of prognosis, we don't have the answer, but we would act very differently. Where are we going in the future? Will ischemia solve it, or are we going to have function added to anatomy, form added to function?
So that's a great question, and actually that was the reason for the other slides, is the realization of what you just said, that alone is not enough. So what the ischemia trial or Hakamovich data shows is if you're a betting man and you have 6,000, you get 6,000 chances, you're going to be correct more often if you do use that number 10% or greater. On a patient-by-patient basis, of course, you're going to be wrong from time to time. So what we're hoping is when we go to the next step and we get the CTA in combination with the PET flow, that we can actually tell you exactly your question. And when you ask me that question, you'll say, no, this one is okay. So this is a 10%, but it's the 10% that you can, it's less than 10% that you don't have to worry about. So I don't know if that's a good enough answer, but that is the what I think is. So it's a matter of how you bet. And in terms of the value system, it's all a question of value for whom. It's a value for the patient, or it's a value for the hospital. And so in terms of value for the patient, you want positive outcomes, and we probably have to do more.
Ernie, that was a fantastic talk, and I mean it's just so incredible that you've selected all the key clinical questions that are unresolved, and you're sort of going after them with your work and research. But my question comes back to kind of taking Spencer's point. If you take clinical practice right now, nuclear imaging, whether it's with PET or SPECT, really the two ends of the spectrum still trouble us. And those of us that work in the cath lab sort of see patients that come through. On the one hand, you do have patients that appear to have significant fixed defects, who come to the cath lab and at least appear to have angiographically normal anatomy. So my question to you is, where does wall motion and perhaps even electrical activity come in to inform whether this is a false positive, an artifact, versus a true? Because a lot of us in the cath lab are being assessed by the number of normal coronaries that come through our cath lab, and sometimes they're driven by some of the artifacts that remain. So that's kind of the one end of the spectrum. On the other end, you showed that nice case example with the inferior defect that had I think it was like a 19% at rest, or 19% at stress that moved up to 15% at rest, and there was only 4% ischemia. But we see patients like that as well who are billed as having fixed, and yet they come in with relatively normal wall motion and may have a 99% lesion. And so my question to you in that scenario is, when they say fixed, does that have something to do with the extraction fraction of the tracer, and is it truly infarction? And again, how does wall motion and electrical activity help tease out that, or is flow reserve the thing that's going to help us in that scenario?
Yeah, so these are real tough questions, right? Uh, the so from the point of view of so the reason for me to talk about that second part, the percent LV burden, is to understand what where the numbers came from. Because the confusion, which I think is maybe what you're pointing out, is some people think that the initial hyperperfuse region is what gives you the percent LV ischemic burden. So the question is, well, if it didn't improve, what was it? Was it it's just you didn't wait long, you didn't have good enough to see the other ischemia, but this is what Hakamovich dealt with when he came up with these numbers. So I would hope we get to the point, I mean, you can tell me if this was happening or not happening, is that patients don't go to the cath lab with just fixed defects. That my understanding is in most cases, unless it's unusual, you actually see ischemia. So part of the reason for that second part, talking about percent LV burden, is so that we can maybe standardize our reports. So we can say, yeah, I definitely saw ischemia there, which is very important for you, but it didn't cross 10%. Now you can decide, as the cardiologist, should I send that should I keep moving with that patient, or is this good enough to say this is a low-risk patient, so I'm not going to worry about it? So I don't know if I answer that question. I can tell you that when I was having my cath, I was told by the fellow, says, well, your study was done with PET, so that's pretty good. I believe the results much more than if they are done with SPECT. And that happens to be the Atlanta concept. And there are some good reasons for that. But of course, SPECT with attenuation correction, better, all these other type of advancements are going to be very helpful. But PET, technically, particularly because of the pharmacological agents that we use, is still a better study than SPECT is.
Thank you very much for coming. Thank you. Thank you.
The preceding program is copyrighted by Emory University.